So we have looked on the screening cohort for a randomized ADAPTcycle trial. ADAPTcycle trial was in phase 3 trial, which compares endocrine treatment plus ribociclib compared to chemotherapy followed by endocrine treatment in patients with unclear chemotherapy indication based on recurrence score, clinical status, in particular nodal status, and response to the preoperative endocrine treatment. And now we have looked on the screening cohort for this trial on about 4,300 patients with complete data for genomic risk, for oncotype DX, for clinical status, and for kind of endocrine treatment given for 2 to 4 weeks prior to surgery, and looked on correlation between endocrine response measured by Ki-67 below and equal to 10% after 2 to 4 weeks of preoperative endocrine treatment, according to the recurrence score, according to the kind of endocrine treatment, according to use of ovarian function suppression, and according to age. So it's very interesting because as we know from our previous trials, endocrine response appears to be lower in premenopausal younger women compared to older women. And this point was important for the discussions of the results for the chemotherapy use in patients, in older patients and in younger patients. And if we think about MINDEC trial, about TELRIX trial, and about REXPONDER trial, and also ADAPT trial performed by our group a couple of years ago. And now we have observed the same rates of endocrine response for tamoxifen only and aromatase inhibitors for younger patients and in older patients. So we have observed only 35% endocrine response for tamoxifen if given in younger women, compared to about 80% of endocrine response after 2 to 4 weeks of AI given in older women, older than 50 years old. But the major interesting new novel finding was that we have observed about 60 to 80% of endocrine response in younger patients if ovarian function suppression was added to tamoxifen or to aromatase inhibitors. So to say it in other words, we have observed the same rates of our endocrine response in younger women as compared to the older women. So based on these results, we think that if adequate endocrine treatment will be used, so ovarian function suppression in high-risk premenopausal women, we should guide our chemotherapy treatment decisions in the same way as also for the older women. In these women, we know that patients up to 3 positive lymph nodes and, for example, recurrence score below 26 do not benefit from AD1 chemotherapy. Based on our results, we think together with the results from the ADAPT trial, that prognosis of patients after endocrine response and favorable genomic profile up to 3 positive lymph nodes also in younger women would be so excellent that there is only very, very little space for chemotherapy use in these patients. Yeah, so it's very good questions. Absolutely clear. We wait all for the follow-up data from the trial regarding the question chemotherapy or not, or endocrine treatment plus ribo in this randomization cohort. But I think also already for now, we have enough data to use endocrine response assessment, in particular, for example, also treatment with ovarian function suppression already before the surgery, together with tamoxifen and aromatase inhibitors, for example, in younger women, together with genomic testing and together with clinical factors to guide our chemotherapy treatment decisions, in particular in younger women. In these women, we have the largest uncertainty regarding the use of chemotherapy. So I think that in particular for these women, our results are already now of importance, because we know endocrine response assessment can be used already now also outside of all the trials as prognostic factor in early hormone receptor positive HER2 negative breast cancer. But if we do it, we should do it, and we should look on the same treatment as we plan to give after the surgery.